So this is part 2
for today.
Looking at obstructive pulmonary disease. What we have left is the remainder of obstructive pulmonary diseases and the restricted types. And then we have to get into infections. And then we're done. So if we look at asthma, it is also in the category of obstructive. And it's also referred to as bronchial asthma. We're going to have 2 main types that we'll look at. One's extrinsic and one's intrinsic. So the list that you see there under extrinsic should make quite a bit of sense. Right? These are things that happen really outside of the body. Like, for example, smoking, ozone, allergy or allergy-induced asthma. Even obesity can lead to asthma, mostly because obesity leads to esophageal reflux disease. And if you have esophageal reflux disease, a lot of times you're going to aspirate a little bit of the contents from the stomach into the esophagus, or into the trachea, excuse me, the windpipe, and that's going to cause an irritation. It's thought to be somewhat of a protective effect, meaning to restrict the airways when you're exposed to an irritant so as to limit the amount of irritant that can come in. And that's why the body does this. So what you see is you see a normal airway cross-section up top in this middle panel. And here you have a constricted airway in an asthma attack or an asthmatic response. You can see how the bronchial smooth muscle contracts down and restricts that ability to pass air. If we look at intrinsic, there's no IgE production. So there's no allergy. There's no pollen that's going to stimulate this. This is going to be intrinsically mediated by things that would happen within the body itself. So, for example, the cold is obviously cold air that comes from the outside of the body. But the problem is usually the way it's supposed to work is the cold air comes in, it's warmed by the airways, it's brought close to body temperature, and there's no problems. But when cold air is brought into an irritated windpipe or a trachea, you can cause constriction to take place as a result of that cold air. Exercise or stress. A lot of the corticosteroids that we have that circulate in the bloodstream during a stress response stimulate bronchial constriction. Okay, if we go up to this upper right and you look down at the bottom 2 figures below it, this is demonstrating an example of an extrinsic asthma attack that's responding to a certain type of pollen. And so this should be somewhat familiar as you're kind of walking through the different steps based upon hypersensitivity number 1. Right? Hypersensitivity number 1, or type 1 hypersensitivity, is an IgE-mediated response. And so you can appreciate how the pollen, the allergen, is binding to a dendritic cell. This acts as an antigen-presenting cell to a helper T cell, showing it to a B cell, producing the IgE antibody. That IgE antibody binding to a mast cell, triggering interleukins to increase the recruitment of new eosinophils to the area, and also triggering, if you go down, the ability of the mast cell to go to the area, degranulate, and cause all sorts of inflammatory mediated activities. So if you take this mast cell and you come down, you see in the immediate phase, what we've got is this degranulation, these chemical mediators, triggering a lot of smooth muscle cell contraction. Vascular permeability goes up, so you start extravasating out all of these inflammatory mediators. These cells can get out into the tissue. Later, in the late phase, you get the recruitment of additional neutrophils into the region. They continue to degranulate. This increases the production of the mucus. There's this massive mucus coating that takes place by the goblet cells that are present. And this is all happening while the airways are restricted. So this would be an asthma attack. Okay? So asthma is considered obstructive pulmonary disease. What does it look like microscopically? I'm going to dim the lights so you can, whoops, so you can see this a little bit better. This is the airways. On the left side, you're seeing the bronchial cartilage right here. You see this bronchial cartilage right here? So you see the bronchial cartilage, and then you see the submucosa, which is over here. All of this is supposed to be open white space. All of that's supposed to be open white space, and now the bronchial lumen is filled with mucus. So if I zoom in higher magnification, which is the lower right image, you can see all of the inflammatory cells that are present, all of the purple dots, right? We also see that there's a recruitment of many, many eosinophils that are part of that late phase and even that early phase response that are in this area. So, for example, this one right here would be an eosinophil. This one would be an eosinophil based upon the shape of the nucleus. Here's an eosinophil right here. And then all of the other single nucleated looking circular cells are going to be neutrophils in the area. Okay, but keep in mind, between this, in the upper left, this bronchial cartilage and the submucosa, this entire material is all mucus, and that's what you've blown up in higher mag on the lower right. Someone asked about bronchiectasis, because they're asking about cystic fibrosis. So bronchiectasis is a permanent dilation of the bronchioles. Usually it's because of a persistent or a long-term obstruction that's taking place. Like, for example, with cystic fibrosis patients. Or it could be a chronic infection that has a lot of necrotizing tissue that's present there. So in this picture on the right of this lung, post-autopsy, a type of obstructive lung disease, bronchiectasis, and there's permanent dilation. You can actually see the dilated bronchi as they've been cut through. You see these holes that show up, right? So as we slice through that, you can see those dilated bronchi. In many of those, you would actually cut through a pocket of pus, right? So in these patients, the sputum or the mucus production is copious. There's lots of it, that's what that means. There's a foul-smelling nature to the sputum. They have shortness of breath, dyspnea, they have a repetitive cough, they're running a fever because they have an infection. And they're at risk for increased bacterial infection as time goes on. So it's probably likely they're going to get other ones as it continues. So cystic fibrosis, unfortunately, is an inherited disease. Someone asked about it. In the end stages of the disease, you would see bronchiectasis as one of the results. The disease causes a thick mucus to build up in the lungs, as well as the digestive tract. It actually is one of the most common lung diseases within children and young adults. The name comes from the characteristic scarring or fibrosis that happens within the lung and also in the pancreas. So the patients usually have difficulty breathing as a result of these types of changes within their lungs. Okay? So that wraps up obstructive diseases. Now we're going to switch into restrictive diseases. So restrictive diseases are ones, if we go back to our introductory picture. That's what's shown here. Restrictive diseases are going to negatively impact the ability to expand the chest cavity. So there's a reduced lung capacity. The expiratory volume is near normal, or it might be proportionally reduced, but really the issue is on the inspiration side of things, bringing things in. They cannot inhale as much as a normal individual. A lot of chest wall disorders are going to cause restrictive type of diseases. Some chest wall disorders would be things like pleural diseases, or even obesity can cause restrictive type of diseases. And then one that we're going to look at more actively is what we call acute respiratory distress. Acute respiratory distress syndrome. Well, the characteristics of these restrictive diseases, we get a lot of fibrosis showing up in the lung tissue. So this is a trichrome stain through pulmonary fibrosis in the lung. All of the blue colored stain is indicative of excessive collagen tissue that shows up. That's part of this fibrosis or the scarring that's taking place within the lungs itself. It could be acute or chronic disease that could cause a problem. A lot of them are diseases that are going to infiltrate into the lungs. So, for example, acute respiratory distress syndrome. What is that? What is ARDS? So ARDS is a disease known as acute respiratory distress syndrome. It has a couple of other names. It's called lung shock. It's also referred to as traumatic wet lung or diffuse alveolar damage, DAD. What happens is you get this change that takes place within the alveolar capillary architecture. It can be life-threatening because the patient can't breathe. Respiration is actually compromised. And the neutrophils that take place or that are recruited to the area play a major role in causing a lot of tissue damage. ARDS, acute respiratory distress syndrome, was a major cause of death in soldiers during the Vietnam War. That's why there's a picture here of Vietnam, the war. In the 1980s, acute respiratory distress syndrome mortality was about 50 to 60%. That's not that long ago. Now it's down in the 30s, the mid to low 30s mortality rate. This is worldwide numbers. Okay, these numbers are improved in the United States, of course, because something goes wrong and there's a clinic within a couple of miles of where you're sitting. You can always get to some place and get a case of antibiotics if you need it. The key damage is that there's massive inflammation that's stimulated by the lung itself. These neutrophils that are recruited to the lung release tons of enzymes, proteases. Those proteases start changing and degrading the architecture of the lungs. This is kind of what we saw with emphysema, right? If you go back to emphysema, the problem with emphysema is if you have recruitment of inflammatory mediators, maybe not as much as what happens with ARDS, but it's enough over a long period of time that you slowly start chewing away at the architecture of the lung and you go from this to this. Here this happens a little bit more quickly because it's an infection, if you will. Okay? So these neutrophils are releasing proteolytic enzymes, proteases, a lot of free radicals, causing tissue damage as well. A lot of other cytokines that are recruiting more inflammatory mediators to the area to raise the level of the inflammation. Now, so how do we get it? Right? How do we get it? Well, there's a couple of ways. There's two main ways: indirect or direct. So indirect would be like septic shock, traumatic shock, or even in burns. So Direct injury is using diseases like pulmonary infections, diffuse pulmonary infections. So SARS, there was a period in our recent history where there was major SARS outbreaks in Asia. Do you guys remember this? And people were getting on airplanes, and they were traveling in the airplane from one country to another in Asia, and they were infecting people on the airplane. Right? How many of you like just shut off the air vent when you get on the plane? That recycled air. Yeah, I totally do. Like, you know, especially if someone's in the back going, all right, you're like, ooh, right? Because like in 5 minutes, that air is blowing right in my face. So SARS, this is severe acute respiratory syndrome, SARS. And this is a direct way that it can actually infect the lungs. Now, why is there this picture of this little palm civet? That's this upper right. Okay, well these palm civets are little mammals that are found in Asia. They weigh about 4.5 to maybe 11 pounds. And they're kind of cute little creatures, but they actually do carry a lot of these diseases. They carry a coronavirus, and that coronavirus is shown in this lower right image. Okay, this coronavirus has an enveloped virus that has a helical symmetry to it. There's a single positive strand of RNA in their genome, and that's what they use to actually infect the host cell. And so the problem is in Asia, those are considered a food source. So they're infected with this coronavirus on the bottom right. You can imagine the people that are eating these little civets, you know, their civet stew or whatever, however they eat it, they're getting infected with this this virus. Okay, and it targets the pulmonary tissue. Other ways of direct injury are aspiration, meaning contents from the gut come in, like what you see with near drownings. Okay, you're getting a lot of fluid that goes into the lung and causes damage, causes inflammation. Could be chemical injury, okay, where you know, a patient is exposed to toxic fumes, and that causes chemical damage to the respiratory epithelium. Or it could be even in the hospital with a mechanically induced respirator. Okay, if a patient's on a respirator and the settings aren't correct, if those settings aren't dialed in for the appropriate physiologic settings, you could cause damage to the epithelium if you overinflated that patient based upon their height. Right? Because our lung size is really tied to our height as an individual, not necessarily our weight. Okay, so a 6'6" individual is going to have larger lung capacity than a 5-foot individual. Okay, so and we need to know that. So you need to know how to set that respirator so that you don't cause mechanical damage and lead to a respiratory problem. So if we look at acute respiratory distress, here's a list of problems that the patient would have. Shortness of breath. What's tachypnea? Fast breathing. Tachy meaning fast. They're cyanotic, okay, because they're not able to ventilate well or oxygenate well. They have hypoxemia. So the partial pressure of oxygen in the blood is many times below 60 millimeters of mercury. They have lots of lung edema, lots of fluid within the lungs. They're non-responsive to oxygen therapy, or they're what we call refracted to oxygen therapy, because the lungs themselves have a lot of inflammatory scarring. Right? The lungs themselves look like this tissue. Remember, I backed up like 3 slides. a lot of scarring of the lungs that don't allow for oxygen exchange. If we look at this radiograph, X-ray, you kind of see on day 5, sort of early on, and what you're looking at is you're looking at the dark black space that makes up the chest cavity. Okay, that's the air. You can see here's the diaphragm down here towards the bottom. And if you go from day 5 to day 10, you see how much more white is showing up in the lungs. That's fluid. Look here at day 13. Look at the right lung. Look at down here on the right lung, right? Sort of where, ribs 9, about where rib 9 is. You can see it's almost completely shadowing out or whiting out where the ribs are. And then see at day 15, you can see things are starting to clear up. Okay, so this is this lung edema that you're appreciating in this picture. Now, lastly, we need to talk about lung infections. That's the last thing for today, are lung infections. Pneumonia. This is the one that we're really going to characterize the most. So the most common cause of pneumonia is actually bacterial. It's the most frequent. It's very common that a patient will develop a lung infection, okay, and they have bronchitis, and that bronchitis isn't treated well, and it develops into pneumonia. Okay? What you're seeing here is streptococcal pneumonia. In a scanning electron micrograph up on the far right, and then histologically you're looking at your strep in a culture. Well, bacterial isn't the only type of pneumonia. But pneumonia in of itself is an infection of the parenchymal tissue, the lung. That word parenchymal again means the functional tissue of that organ. So if you have an infection of the functional tissue, that infection can either be bacterial, which is the most common, but it could also be fungal or it could be viral. Now, the way that we unfortunately commonly discover if it's fungal or viral is the patient has pneumonia, it is on like their 3rd regime of antibiotics, and they're not getting any better. And then usually the physician says, well, it must be viral. It must be viral. Okay? But we don't necessarily really test. Okay? We don't go in and take swabs of your respiratory epithelium, throw it out in culture to determine if it's bacterial or viral, or if it's a fungal infection. But all 3 could actually cause it. There's many types of syndromes, if you will, and we're going to focus on a few. So the types, the community or the typical acquired is bacterial, the most common, right? That's that first one. This one's basically saying the most common being bacterial. Atypical community acquired is fungal or viral, what we just said. Now, some other categories or types, if you will. Nosocomial is usually considered hospital-acquired pneumonia. It's a gram-negative stain, but it is what we typically find when someone goes to the hospital for like a heart procedure and they come out with pneumonia. It's usually what we call nosocomial pneumonia. And then there's chronic pneumonia. Chronic pneumonia is one that, like the word indicates, it sticks around long term. And chronic pneumonia could be either bacterial, fungal, or viral stimulated. It's just lasting for months and not subsiding. All right, so what's going on with pneumonia is really best described in this lower histology image. Okay, and then we'll get up to the top here at the end. Well, in the left image, the lower left, you see that the alveoli are the lower right, you see the alveoli are aerated. In the lower left, you see that they're filled with neutrophilic exudate. This neutrophilic exudate is found in specific areas where the infection is prevalent. Okay, and so this is kind of a cool picture because you can see this nice clear delineation of sort of normal aerated lung tissue and then neutrophilic exudate. Okay, and this is what the problem is. There's clearly an infection, and that infection is propagated. Now, we have different types of locations that we can discover pneumonia, where you'll see this sort of demarcation. If you go up to the top schematics, you're seeing red hepaticized and gray hepaticized. The red hepaticized is more of a diffuse type of pneumonia, and it's seen with what we call lobular pneumonia, L-O-B-A-R. The red appearance of the tissue of the lobes is indicative of a lot of hemorrhaging that's taking place in the tissues. In contrast, our gray hepaticized is often seen with what we call bronchopneumonia. Bronchopneumonia is affecting the bronchial airways more so than the lobes themselves. Okay? So gray hepaticized is bronchial, and red hepaticized being more lobular in nature. Okay. What I would like for you guys to be able to do, this is a take-home assignment, because I think it's a good tool for you guys to be able to determine how well do you understand emphysema versus chronic bronchitis. Okay? So I want you to draw and define the major features of both. This says person A and person B. But I really want you to do this as homework. This is part of the study. What I'm looking for is kind of for you to recapitulate that figure that shows pure bronchitis and pure emphysema, so that you're comparing and contrasting the two different disease types. Okay? If you can't draw, fine, make a table. Make a table, and on the right side put emphysema, and on the left side put pure bronchitis. Understanding that you might have patients that have elements of both. Any questions on this activity? Any questions on the lecture itself?